I don't want to mislead you. Did Rami shutting the door? Or did you? Okay, okay.
Yeah.
Yep. All right. You have a microphone?
What is that?
Really low. All right, everyone, we're just about to get started, so I'll wait for you guys to grab your food. We'll take our seats. This microphone is really low, so I'm just crouching behind the screens here. Welcome everyone, and thank you for joining us today for our What's New in Addiction Medicine. I'm very pleased to do the introductions today. My name is Paxton Bach. I'm one of the addiction docs here and the program director for our fellowship program. And I'm really happy to have Dr. Elise Jackson here today, giving our rounds. Dr. Jackson is a PGY5 in the general internal medicine program here at UBC and is concurrently completing her fellowship in addiction medicine through the BC Centre on Substance Use. She attended med school in Toronto before moving to BC for residency. And after graduating, she plans to practice community GIM with emphasis on addiction care to rural and underserved populations in BC. Dr. Jackson is going to be speaking to us today about a really topical subject and one that I think blends both of her interests and areas of expertise quite nicely, and one that I know that there's lots of discussion on these days, not just at St. Paul's, but across North America. So she's going to be talking about managing infective endocarditis in people who use drugs. I'll turn it over to Dr. Jackson, and I'll be back to help field some questions once we're done.
Thanks, everyone. Thanks for having me today. I'm excited to come and chat about this topic. I think it's something that both on the addictions team and the internal medicine teams here, particularly at St. Paul's, we see a lot of. So just starting off by acknowledging that we are on the stolen and unceded territory of the Coast Salish people, including the Musqueam, Squamish, and Tsleil-Waututh. I think that this is important for us to acknowledge always, but I think particularly when we're talking about people who use drugs, recognizing that because of the legacies of colonization and settler violence, that these are issues that disproportionately affect Indigenous people, and something that we should keep in mind when we're caring for these populations. I have no disclosures. In terms of objectives for the talk, so I'm going to caveat this by saying that obviously infective endocarditis is a huge topic, and so I'm not going to go through all of managing infective endocarditis. I don't have the time or the expertise to do that, but I'm going to focus more on kind of the nuances and specifics of care when we're treating people who use drugs who have infective endocarditis. So understanding the epidemiology, the microbiology, and the management of injection drug use related infective endocarditis and how this differs from other cases. Review primarily kind of evidence around the management, both medical and surgical intervention, and then in particular to highlight the role of kind of the interdisciplinary team and the addictions teams in managing patients with injection drug use related infective endocarditis. So start off a little bit of an introduction to infective endocarditis, and specifically infective endocarditis associated with injection drug use. So just to kind of set the stage, infective endocarditis refers to an infection of the endocardium, which is the inner layer of the heart. Overwhelmingly, this affects the valves of the heart specifically. In almost all cases, this is a bacterial infection, but in some rare cases, and about 2% can be fungal. The most common causative bacteria are Staph aureus, which account for about a third of cases, as well as then viridans group strep, other strep species, other non-aureus staphylococcal species like coag neg staph, as well as enterococcus. a sizable population, about 8 to 10%, are culture negative, meaning that we never actually isolate a causative organism, and about 1% and growing are polymicrobial, meaning there's multiple bacteria or microbes involved. In terms of risk factors, the major ones are structural heart disease. So this can include people with existing valvular or congenital heart disease. It also includes people who have a history of infective endocarditis and may have some scarring or residual structural changes to their valves that will predispose them to recurrent episodes. People who have a prosthetic valve are also highly predisposed to infective endocarditis. Obviously, having any kind of foreign material will predispose you. Injection drug use because of the high rates of kind of bacteremia and introduction of bacteria into the blood. And then anything else that introduces a transient bacteremia, such as dental procedures, particularly gum manipulation, and then certain GI procedures like esophageal dilatation. As the internal medicine folks in the audience will know, the main criteria we use to diagnose endocarditis are the Duke criteria. And I actually didn't realize until I made this presentation that they actually were updated just this year. So up until then, we've been using the modified Duke criteria from 2000. So underwent a bit of a revision this year. So we have kind of 3 categories of criteria. There's pathological criteria, which is microbiological or histologic findings on pathology specifically. So that requires a surgical intervention and removal of material to look at. If someone doesn't have surgery or we haven't got those pathologic criteria, there's then major criteria, which are positive blood cultures or other microbiological lab tests. And there's a lot of specifics about like what are considered typical bacteria and what are sort of the criteria of how many blood tests or how many blood cultures, how far apart to meet criteria. I'm not going to go into all of those details. There's then also imaging findings, so echo, cardiac CT, or PET findings. And then a new addition to the 2023 criteria was the addition of surgical findings, which are essentially intraoperative findings like evidence of a vegetation or an abscess, but not meeting the full pathological criteria. And then you have your minor criteria, so people who have a predisposition, such as injection drug use, a history of previous infective endocarditis, a prosthetic valve, all of those kind of predisposing risk factors we talked about before. A fever measured at greater than 38 degrees, vascular and immunologic phenomena, which again, I'm sure all of the internal med folks have been questioned about at some point, but I'm not going to go into detail. And then microbiological evidence not meeting major criteria. And then some of the new criteria are PET evidence that don't meet your major imaging criteria and changes on physical exam, so a new murmur suggestive of regurgitation. You make your diagnosis using these Duke criteria. So to meet a diagnosis of definite infective endocarditis, you have to have at least one of those pathological criteria. Alternatively, you can have 2 major criteria, 1 major and then 3 minor criteria, or 5 minor criteria. Possible infective endocarditis is considered 1 major and 1 minor, or 3 minor criteria. And then we essentially consider the diagnosis rejected if either there's a clear alternate diagnosis, they don't meet these criteria, there's no recurrence of imaging or blood culture findings despite antibiotics for less than 4 days. And this is an example of what an infective endocarditis vegetation might look like here on the valve. So you essentially have this growth on the valvular tissue. In terms of changes in the updated criteria, there's been between the 2000 and the 2023 criteria, there's been the addition of multiple bacteria to the list of typical organisms. This is just reflected essentially a change in the microbiology of infective endocarditis that we're seeing. So things like Staph lugdunensis and Enterococcus faecalis have been added to typical bacteria, and there's also several more bacteria that are considered typical if you have a prosthetic valve. There's changes in some of the PCR testing for our other organisms like Coxiella, Bartonella, Trophorema, and then changes in imaging, including the addition of cardiac CT and PET scan. And then the new major criteria being this kind of intraoperative evidence, such as vegetation or abscess that doesn't meet full pathologic criteria. And then they've also expanded some of the minor criteria. So that's kind of just an intro to infective endocarditis in general. Transitioning to talking about infective endocarditis in people who inject drugs or people who use drugs. Over the last sort of couple of decades, there's been a huge increase in the cases of injection drug use related infective endocarditis. So based on one study, from 2000 to 2013, overall hospitalizations for infective endocarditis rose 38%, but hospitalizations for infective drug or injection drug use related infective endocarditis increased 238%. So like a multiple fold increase in the amount of cases we're seeing. The population affected is typically much younger than in cases not associated with injection drug use. So mean age is sort of usually in the 30s, depending on the study you look at, kind of 36 to 38 versus 50 or older for non-injection drug use related infective endocarditis. And then they often have higher 1 year or more long-term mortality compared to people who don't use drugs who get infective endocarditis, despite having relatively similar short-term outcomes in the first kind of 1 to 3 months. And ultimately, infective endocarditis is felt to be responsible for about 5 to 10% of deaths in people who inject drugs. So this is, among the population that we see of people who use drugs, this is a very high cause of mortality. This was a study that came out of Manitoba looking at rates of infective endocarditis over time from 2004 to 2018. This blue line is cases associated with injection drug use. And so you can see that especially since sort of 2015, 2016, when the overdose crisis was sort of considered a public health emergency. Since then, in particular, the cases have risen. And in Manitoba now, actually, as of 2018, have eclipsed the cases not associated with injection drug use. So depending on where you are, there's actually more cases associated with drug use as compared to not associated. I thought this was a bit of a busy table, but a really interesting study. They did a modeling study essentially looking at people's risk of developing endocarditis over their lifetime, depending on their frequency of injection use and their kind of high or low risk practices. So high frequency was considered more than once per day, and high infection risk practices were considered to be things like sharing needles or not cleaning the skin before injecting. And so if you look, they essentially created this model looking at what your probability of developing endocarditis over your lifetime was. So someone who begins injection drug use at age 20 and has high frequency, so more than once per day, and high risk injection techniques has essentially over a 50% chance of developing endocarditis over their lifetime. I think also interesting to note that even with high frequency, if you lower their, teach them about, or if they are having safer injection practices, you can really dramatically reduce that. But I think an interesting kind of representation of how common this is among people and the likelihood of people developing this, by age 60, depending on their kind of frequency of use. This was also from the study in Manitoba showing essentially the distribution of ages between people who use drugs and people who don't use drugs who got infective endocarditis. So again, you can see certainly skewed much more towards a younger population. So again, if people are dying of this, we're losing more kind of life years that people would have to live. In terms of valvular involvement in injection drug use related infective endocarditis, so tricuspid valve is by far the most common, depending on studies you look at. Somewhere between 58 and 77% of cases involve the tricuspid valve, and about 90% in total of people who present with right-sided infective endocarditis are people who inject drugs, as compared to 20% of people who present with left-sided endocarditis. So left-sided is considered your aortic and your mitral valve. Right-sided is considered your tricuspid and pulmonary valve. For whatever reason, the pulmonary valve never seems to be involved. So it's usually just tricuspid, aortic, or mitral. That said, despite the prevalence of tricuspid valve involvement, surgery is actually most common on the aortic valve, followed by the mitral valve, followed then in last place essentially by the tricuspid valve. This is often to do with the risk associated with left-sided endocarditis of embolic phenomena and heart failure, leading to kind of more severe consequences requiring surgery. And then it's actually quite common for people to require multiple valve or intervention on multiple valves, so somewhere between 20 and 55%. Comparing the microbiology of infective endocarditis in people who use drugs compared to those who don't. So similar to people who do not inject drugs, Staphylococcus aureus is the most common single organism, but important to note, so in the kind of gold color here is people who inject drugs, and blue is people who don't. A very, very significantly higher percentage of MRSA is involved compared to methicillin-sensitive Staphylococcus aureus, so have much higher rates of MRSA and much higher rates as well of Pseudomonas as well. Lower rates of Enterococcus and Streptococcus, but again, kind of eclipsed by those high rates of MRSA. So when we're thinking about antibiotic, particularly empiric antibiotic choices for our patients who use drugs, making sure we're covering MRSA and potentially gram negatives like Pseudomonas if there's a high suspicion. Getting into kind of the medical treatment, which primarily involves sort of antibiotics. There's a couple of really helpful guidelines. I'd say the primary ones that I found of value were the ESC, which is the European Society of Cardiology, actually just revised their guidelines in 2023. And then the American Heart Association and Infectious Disease Society of America guidelines from 2015. That should say American College of Cardiology and the Canadian Cardiology Society put out a guideline on valvular disease in 2020, which included infective endocarditis. And then the AHA, the American Heart Association, actually put out a scientific statement specifically on managing infective endocarditis in people who use drugs in 2022. So lots of actually really helpful resources out there, which I will try to very briefly summarize, but essentially principles of antimicrobial treatment in patients with infective endocarditis in general is that most of these patients require a relatively long duration of treatment, typically 4 to 6 weeks, but we'll get into some of the exceptions to that rule. Almost exclusively, patients will require or receive treatment via IV route, but there are also exceptions to that, which we'll get into. Obviously, your antibiotic should be targeted to the susceptibility of the isolated organism. And as I said, if you're starting empiric therapy in people who use injection drugs, should make sure that you're always covering for MRSA, given that almost 50% of cases involve MRSA. In prosthetic valve endocarditis, usually additional agents like rifampin are needed to treat the development of a biofilm. This is essentially a summary of kind of antibiotic recommendations coming from the 2015 American guidelines. I'm not going to get into these in detail, but given that the vast majority of cases in people who inject drugs are right-sided endocarditis of the tricuspid valve, we'll talk a little bit more about managing right-sided endocarditis in people who inject drugs specifically. So typically, right-sided endocarditis will have better outcomes than left-sided endocarditis. And as a result, or in conjunction with that, there is evidence that people can actually do equally well and that 2-week regimens are non-inferior. So we can actually offer patients with a right-sided endocarditis a 2-week course of therapy rather than 4 to 6 weeks if the following criteria are met. So specifically that MSSA is the positive organism, that there's good clinical and microbiological response to treatment. As long as there's not a huge vegetation, so you want the vegetation to be less than 20 millimeters, and as long as there's evidence, or as long as there is no evidence of metastatic infection, so that would include embolic phenomenon or involvement of left-sided valves or prosthetic valves, or if there's other complicating factors like severe immunosuppression. Aminoglycosides are not required. You can just use, depending on the person, usually something like cloxacillin or cefazolin to treat. And if you do have someone with MRSA, you can use daptomycin. Vancomycin is not recommended for these 2-week regimens because it has reasonably poor penetration. And so if someone requires treatment with vancomycin, they'll require a longer duration of therapy, but daptomycin for 2 weeks is considered to be adequate for MRSA. So obviously, for patients to be receiving IV antibiotics, 2 weeks is certainly, for most people, preferable to 4, particularly if it requires them to be staying in hospital or to be receiving IV antibiotics in an OPAT setting, like an outpatient antibiotic treatment center. But obviously 2 weeks is still quite a long time to stay in hospital. And a lot of people may choose not to stay for that long for various reasons. And so, a question that gets asked a lot is, what about options for oral antibiotics? I will caveat all of this by saying that data is somewhat limited, but there is some emerging evidence of the use of oral antibiotics to treat infective endocarditis, and specifically in people who use drugs. This can be helpful in this patient population, both because patients may have quite challenging or quite limited vascular access from a history of injection drug use, and also because of the high rates of patients leaving hospital. So one study that I found showed that essentially 1/4 of patients left hospital before finishing IV therapy, and overall 1/3 of people didn't complete treatment. Depending on where you are, I'd say that's even maybe like a bit conservative. But certainly there's a large percentage of patients who are unable to complete a long-term IV therapy course. So looking at oral antibiotics in patients with injection drug use related infective endocarditis, there's actually reasonable data looking at oral antibiotics if they have a right-sided, so a tricuspid valve infective endocarditis as a result of MSSA. There's 2 main studies that have been cited by the guidelines looking at 4 weeks of oral ciprofloxacin and rifampin in combination as compared to IV therapy. And the cure rates in both studies showed were over 90% in the oral arm of therapy, and also actually had less toxicity than IV therapy, so less renal dysfunction and other complications. So it's now actually quite common in a lot of the guidelines to recommend that oral ciprofloxacin, so 750 milligrams twice a day, and rifampin, 300 milligrams BID, is recommended, probably not as a first-line option, but is considered an adequate alternative if a completion of, or if a full course of IV antibiotics isn't possible. Obviously, that's with the caveat that the strain is susceptible to both of these drugs, that it's an uncomplicated infective endocarditis. So again, this does not apply to people who have multiple valve involvement or who have, extensive embolic complications. And you want these patients to have fairly closely monitored adherence and be fairly certain that they're getting the lion's share of their antibiotics. There's also lots of evidence for partial antibiotic regimens. So this is people who are initiated first on IV treatment and then transitioned at some point in their therapy once they're considered stable, and once they have cleared their bacteremia, to be switched to oral antibiotics. So this was a study on partial oral antibiotic therapy from 2020 that was done specifically in people who inject drugs with invasive infections. So that included not only infective endocarditis, but also osteomyelitis, septic arthritis, and epidural abscesses, and compared essentially 3 groups of patients. So those who received a full course of IV treatment, those who received a partial course of IV treatment followed by no oral antibiotics, and then the third group being those who received a partial course of IV antibiotics and then oral antibiotics if they then left against medical advice before completing their full course of treatment. It essentially showed that groups 1 and 3, so the full antibiotics or the IV, or sorry, the full IV or the partial IV and partial oral had equivalent rates in terms of readmission. And then the group who did not receive additional oral antibiotics had a much higher, actually double the rate of readmission with recurrent sepsis, relapse of their endocarditis. And interestingly, kind of alluding to what we'll chat about later, addiction medicine consultation was actually statistically associated with a lower risk of readmission and risk of reinfection. So it's actually, you know, smallish studies, but reasonable evidence to suggest that if a patient is unable to complete a course of full IV therapy, that oral antibiotics are an appropriate alternative. In terms of left-sided endocarditis, there's less evidence for people who use injection drugs. Some of the internal med folks may be familiar with the POET trial, which looked at oral antibiotics for left-sided endocarditis. And this compared a full course of IV antibiotics compared to 10 days of IV therapy and then being stepped down to oral antibiotics. And it showed, similar to other studies, that partial oral therapy was non-inferior to IV therapy. I think the limitation of adapting this study to the population that uses injection drugs, I'm just going to pause while there's an announcement.
Code white, Merard 2 north. Code white, Merard 2 north. Code white, Merard 2 north.
The limitations were that there were, in this study of over 400 patients, there were only 5 people who used injection drugs, and only 22% had Staph aureus, with none of them actually having MRSA. So how applicable this is to our population, I think, remains to be seen. I don't know that a lot of people would feel comfortable discharging someone with a left-sided MRSA endocarditis on oral antibiotics, but certainly for right-sided, there's reasonable evidence. Some other emerging treatment options are dalbavancin, which is a semi-synthetic lipoglycopeptide in the same class as vancomycin. And it's approved to treat gram-positive skin and soft tissue infections, including MRSA. The benefit of this drug is that it has a super long half-life of about 14 days, which allows it to be administered every 1 to 2 weeks. So there are also some emerging studies looking at the use of dalbavancin in patients with infective endocarditis. So there was this one review from earlier this year that reviewed essentially 16 studies for a total of 170 patients, where Staph aureus was the most common organism, of which about 50% of those were MRSA and 50% was MSSA. The clinical efficacy was over 90% and was found to have a cost saving of about $9,000 per patient, largely because these patients then didn't need to be hospitalized for as long, because they could get a once a week or once every 2 week dose of dalbavancin. In most of these cases, this was also kind of a step down therapy. So on average, people would receive about 3 weeks of full IV treatment, followed by 3 weekly doses of dalbavancin. The major limitation to this is how available this is in Canada. I know it's been approved by Health Canada, but I don't believe that it is sort of widely commercially available yet, but I think would be an interesting option. I don't know, maybe Dr. Weaver or other folks know if it's available in Canada. Yeah, can't get it. But anyway, maybe at some point an interesting option. A couple of other considerations when in antibiotic treatment for people who use injection drugs is considering drug-drug interactions with some of our opiate agonist therapies or interactions with the drugs themselves. So keeping in mind that rifampin is a strong inducer of CYP3A4, which is also the enzyme used to metabolize methadone. So people may need a significant increase in their methadone dose to continue to achieve kind of effective treatment of their opioid use disorder. Also note that linezolid can cause serotonergic effects. And so in conjunction with other serotonergic drugs, whether that's SSRIs or other prescription medications that they're on, and also in conjunction with opioids like fentanyl and methadone, you need to be cautious of serotonin syndrome. And then finally, monitoring for QT prolongation in patients who are on certain antibiotics, such as fluoroquinolones that cause QT prolongation. particularly if they're taken in conjunction with methadone. One question that gets asked a lot is about PICCs in people who inject drugs. And so PICCs are peripherally inserted central catheters. So these are catheters that essentially have an outlet basically in the superior vena cava entering into the right atrium of the heart, but are inserted peripherally and essentially provide a more stable long-term option for people receiving IV antibiotics. The concern among many people, of course, is that people who inject drugs will use their PICCs to inject. And so this often leads to patients who inject drugs not getting PICCs, despite it being kind of a therapeutically indicated intervention. Interestingly, looking at the literature, there's not actually significant evidence that there's much higher complication rates among people who use injection drugs compared to the general population. And this one paper that sort of was a review paper said there's no substantial body of evidence that PICC lines in injection drug users, not great terminology, but result in more serious infections, increased overdoses, or increased morbidity or mortality. A couple of specific cases or specific studies, including a systematic review of about 800 patients, looked at PICC-related complications, so specifically infections, venous thrombosis, and dislodgement, and showed essentially that the complication rate among people who used injection drugs was about somewhere between 1 and 4 complications per 1,000 line days, compared with an average of 3 to 5 per 1,000 line days in people who don't inject drugs. So essentially no significant difference in concerns of recurrent infection, line sepsis, bacteremia, or thrombosis. And interestingly, another study that looked at PICCs in people who use injection drugs showed that the rate of recurrent bloodstream infections was higher among those staying in hospital compared to OPAT. So I think people are concerned often about sending patients out into the community with these PICCs because they perceive it as being higher risk, but that isn't actually really borne out in the literature. Going to transition to talking about surgical management of infective endocarditis associated with injection drug use. I'll caveat this by saying that I am certainly not a surgeon, thank God. So this is all from the perspective of a non-surgeon, and I will not be talking specifically about surgical techniques, but more about just what the evidence is around surgical intervention. So similar to the rates of infective endocarditis associated with injection drug use, the rate of surgery for these conditions has also increased. So about a 2.7-fold increase from 2011 to 2018, compared to a 1.4-fold increase in non-injection drug use related infective endocarditis. This isn't a great graph because they decided to only do half a year in 2011 and 2018, but essentially the other years you can see that the proportion of people who use drugs is increasing among those who were undergoing surgery for infective endocarditis. In this study, about 16% of them were repeat surgeries. And similar to the overall age distribution for infective endocarditis in general, the average age among those who used drugs was 36 years old versus 60 for those who did not. And again, this is quite a high mortality condition and a high mortality procedure. So the operative mortality in these patients was about 6.7%. And then post-operatively, the in-hospital mortality was about 5.9%. So over a 10% mortality within the first month or so. This is a bit of a busy slide, but basically to say the indications for surgery in infective endocarditis essentially fall into 3 main categories. One is heart failure. So people who have refractory heart failure despite medical intervention, uncontrolled infection. So that's sort of persistent bacteremia beyond 1 week, or evidence of enlargement of the vegetation itself despite appropriate antibiotic therapy. And then prevention of embolism. So this is typically in patients who have quite large vegetation, so usually greater than 10 millimeters. In right-sided endocarditis specifically, sort of a similar set of criteria, usually to do with symptomatic heart failure, so right-sided ventricular dysfunction, requiring respiratory insufficiency, requiring ventilator support, and again, the large vegetation. So on the left side, it's usually 10 millimeters. On the right side, it's usually 20 millimeters is the cutoff for surgical intervention. And we can see essentially that in patients who have an indication for surgery, if they undergo surgical management versus if they undergo medical management, there is a significantly higher mortality in those who have a surgical indication who don't undergo surgery. So this was a paper from Toronto looking at patients who had an indication for surgery versus did not. Those who did not have an indication for surgery actually had 0% mortality. So these were, I guess, typically patients who were less sick. But among those who had an indication for surgery, if they underwent surgery, still a very high mortality, 25%. And those who didn't undergo surgery had a mortality of over 50%. So surgical intervention for those who have an indication for surgery certainly does have a significant mortality benefit. Despite this, as many of us may have come across, there's significant hesitation among certain surgeons, and this is well documented in the literature. So a survey of 94 cardiovascular surgeons said that 50% expressed reluctance to operate on people with a native valve, so their first procedure, if it was associated with injection drug use, and only 36% were reported willingness to offer surgical intervention on a prosthetic valve if there had been recurrent drug use. Another more striking survey of 208 cardiac surgeons said that 93% would be willing to do a repeat procedure on someone who did not inject drugs versus only 25% would be willing to do a repeat procedure in those who do inject drugs. And 63% of surgeons had refused surgery for people who use drugs with a drug use related infective endocarditis in the past, commonly citing the personal choice to use drugs, recidivism, and inappropriate spending of medical dollars. And I think it's important that we recognize that there are cases where the risk-benefit ratio does not favor surgery in these patients, and that as in any case, we need to take the risk benefit into account. And some people may not be appropriate surgical candidates, but I think the issue is when people get automatically declined on the basis of the etiology of their infective endocarditis, as opposed to it being truly a risk benefit analysis. This was from another paper that looked at surgeons' perspectives on injection drug use related infective endocarditis. So a lot of stigma. You've got to blame the patients. I put 80% of it on the patients. They did this to themselves. Interesting that this is what people are willing to put in publications. She already reused once. Likely she's going to do it again. Why do I have to get her through a big operation and go back to square one down the road? When is enough enough? At the same time, I think we also have to recognize that this is a very challenging procedure and that surgeons often don't feel equipped to manage these patients. This was from the same paper that said there's a lot of pressure to operate on them, and it feels like as soon as we do, everyone disappears. And what began as a multidisciplinary approach becomes one service managing surgical complications, managing addiction, managing placement, managing families, and we don't have those resources, frankly. People who are not surgeons, they don't truly understand what it is to do these operations and what it takes to care for them and get them through. And that's frustrating. Do we feel supported in caring for these patients? 100% no. Another person said, the thing we worry about is not the surgery. We love the surgery. It gives us great pleasure. It's where they go back to using and die that is moral agony for us. And so I think there are surgeons who do want to do their best for patients, but don't feel supported in doing that. And I think that's where the multidisciplinary team can come in. Looking at the actual outcomes after surgery, so early outcomes after surgery for patients who use drugs compared to those who don't and undergo surgical intervention, early outcomes, depending on the paper, sort of considered the first 30 days to 3 months, are actually not significantly different between the two populations. So this was one review study. Essentially, none of these, other than this one, which actually showed a mortality benefit for people who did have drug use related infective endocarditis, None of these essentially met criteria of saying that there was, significantly higher mortality in the first 30 days for one group compared to the other. And some studies like this one, which was a review of over 100,000 patients, actually showed that index mortality was lower, both after surgery and for those who did not undergo surgery in patients who use drugs compared to those who don't. And that 30-day readmission rates also were not significantly higher. So essentially, the literature, although there's some variation, shows that in general, early outcomes post-surgery are fairly equivalent for people who do versus people who don't use drugs. That said, some of that is probably accounted for by the fact that this is typically a much younger and a much less comorbid population. And so when you do, this was one study that did actually adjust for cardiovascular risk factors and age and other kind of things associated with operative mortality, did show that the early postoperative mortality is actually a bit higher in people who use drugs, but still not dramatically higher. Where the real kind of divergence in outcomes occurs is more with long-term outcomes. So this was a study of about 510 patients. And as you can see, after the first maybe 6 to 12 months, the cumulative survival does actually begin to separate quite significantly, to the point that people who use injection drugs have much lower mortality several years out compared to people who don't use injection drugs. This was looking at recurrence of infective endocarditis. And so again, recurrence is much higher in people who use injection drugs compared to those who don't, which probably accounts for some percentage of that mortality. This was another study that essentially showed a similar pattern, that people who did not use injection drugs had better long-term mortality outcomes compared to those who did. And the 10-year survival was 63% in people who did not use drugs and 57% in those who did inject drugs. And then this was looking at reoperation free survival. So again, a lot more people who use drugs were either dying or requiring recurrent infection. So, and this has been corroborated in other studies that looks at rates of valve reinfection among people who use drugs versus those who don't, and rates of valve reoperation. So I think while we have good evidence that the surgeries themselves are, with maybe some minor differences, reasonably effective in both, or fairly equivalently effective in both groups, where we start to really see the differences is in long-term mortality and reoperation rates. As I said, I'm not a surgeon, but I did think that this was really interesting. Some novel techniques for tricuspid valve infective endocarditis is essentially this aspiration vegectomy, where essentially you can percutaneously or like transvenously essentially go in and basically like suck off the vegetation off the tricuspid valve. So obviously this is beneficial in that it is a much lower risk procedure. You don't have to have either open heart surgery or, whatever else they do in the surgeries. It's generally a much lower risk procedure and can be quite effective in reducing the risk of septic emboli, and then also just debulking vegetations, meaning that people can then kind of have more success with medical therapy that can just sort of clean up any residual bacteria. So maybe something that people are willing to do, even if they're not willing to provide full operations. Finally, chat about harm reduction and the role of the interdisciplinary infective endocarditis team, and specifically the addiction medicine team. I think especially as we're seeing, short-term outcomes being relatively equivalent between groups and long-term outcomes being worse among people who use drugs, we need to be focusing on, providing stability, getting people onto appropriate opiate agonist therapy to prevent relapse, to prevent reinfection, and to start to close some of that mortality and morbidity gap. This was a really interesting paper that talked about treating the symptom, but not the underlying disease in infective endocarditis, essentially saying that infective endocarditis for many of these patients is really more of a symptom of their substance use disorder as opposed to a primary disease on its own, and that without treating the underlying substance use disorder, we're not going to make much progress in preventing recurrence of their disease. In almost all of the major guidelines, multidisciplinary infective endocarditis teams, and specifically the involvement of an addiction medicine team and addiction treatment is included as like a class 1 recommendation in the European, the American, and the British guidelines. That said, despite this, in a lot of the existing evidence, there is, even though we know that there is mortality benefit associated with these patients being seen by addiction medicine and by a multidisciplinary team, this is often overlooked. So there was one study from Ontario specifically of people admitted with injection drug use associated infective endocarditis, where fewer than a third of them received inpatient addiction care. And in a US study, again, of people specifically admitted with injection drug use related infective endocarditis, less than a quarter had an addiction consult, only 7.8% received OAT, and 0% received naloxone. So I think we have a lot of room to improve in the care of these populations. We also have strong evidence that even in people who do not use drugs who have infective endocarditis, multidisciplinary infective endocarditis teams have been shown to have a mortality benefit. So this was from one study looking not at people who used injection drugs, but just people who in general who came in with infective endocarditis. And they essentially instituted a multidisciplinary team between 2001 and 2002. And you can see there was like quite a significant mortality benefit just to introducing a multidisciplinary infective endocarditis team, not even including addiction medicine, but just the kind of standardization and protocolization of procedures and the kind of wraparound support that comes with having a multidisciplinary team has been shown to have quite a significant mortality benefit. I think then when you add in addiction medicine treatment and peer support and social work and all of that, that this difference would probably only be increased. In terms of some of the models of interdisciplinary teams, so this is the Second Heart team out of McMaster. So this is what their model looks at specifically. So they have a cardiac surgeon, an infectious disease physician, a family, and they have, from listening to them talk about it, they have sort of one specific cardiac surgeon and one or two ID docs who are specifically involved and who they send all referrals to, ensuring that patients are set up with appropriate primary care, that they're all seen by addiction medicine, and then most importantly, that they have a peer support worker who sees them every 1 to 2 weeks for a year following their discharge, and a systems navigator who can help manage things like housing, social supports, all of that kind of stuff. This is the model out of a group in Yale, which is really essentially very similar. Addiction medicine, anesthesia for operative management, cardiac surgery, cardiology, ID, medicine, social work, nursing, and care management. And all of these are, a lot of these groups are kind of in their early stages, but some of the internal data from the group out of Yale, not published, not a randomized control trial or anything, but is quite encouraging of 0% of the 26 patients that they have treated have left against medical advice, 100% have completed antibiotics, 100% have received opiate agonist therapy while in hospital, compared to the like 8% in some of the other studies, and mortality at 6 months is only 4%. So I think there's still a lot that can be done in terms of research and providing hard data on the effectiveness of these groups, but I think certainly early evidence shows that these are very effective and really an essential part of our treatment. There have been studies looking specifically at the effect of opiate agonist therapy in injection drug use related infective endocarditis. So they looked at a cohort of 786 patients who did or did not receive OAT following hospitalization for infective endocarditis. Again, like a truly dismal percentage of people actually received treatment, only 5.7%, but those who did had a statistically significant lower overdose rate, which we would expect, but not only that, but a lower 1-year rehospitalization rate for their infective endocarditis and other presentations as well. So 162 versus 254 presentations per 100-person year. So we have quite strong evidence that providing OAT to these patients has a benefit, not only in terms of overdose, but in terms of the outcomes of their infective endocarditis in general. There's also strong evidence that providing harm reduction to these patients has not only a benefit in terms of overdose, but also a reduced mortality, reduced recurrence of their infective endocarditis, and increased engagement with treatment. So some of the interventions they've looked at are an addiction medicine consultation, an OPAT referral, and then safe injection and safe use teaching. And going back to that modeling study from the beginning that looked at sort of what someone's cumulative lifetime risk was for developing endocarditis, they also did this modeling that showed essentially someone's risk of dying of infective endocarditis depending on their frequency of use and then their injection techniques. So even if you compare these first two, both of which are high frequency, so more than 1 injection per day, just by reducing someone's infection, or just by reducing the risk associated with their injection technique, the chance that they will die of infective endocarditis goes down from more than 50% to like, I don't know, 5 or 10. So we really should be providing strong, harm reduction teaching to these patients. And in terms of harm reduction, we should be providing obviously sterile injection supplies and teaching them about techniques, teaching about alternate routes of ingestion. So even if someone doesn't want to stop using, could they switch to smoking or some other form of ingestion that would reduce their risk of recurrent bacteremia? If they do have a PIC, teaching them how to use it safely, and then obviously providing everyone with naloxone. So yeah, in summary, infective endocarditis associated with injection drug use is a very prevalent condition among people who use drugs with high morbidity and high mortality. Oral antibiotic regimens are a reasonable alternative to IV therapy for those who can't complete a full course of IV treatment. Short-term surgical outcomes are relatively equivalent between people who do and do not use injection drugs, but long-term outcomes are worse among those who do use drugs, and there's certainly a big gap that can be closed there. And then multidisciplinary teams and addiction medicine and addictions care are essential for people with infective endocarditis. I'm going to finish by giving a quick shout out to the Canadian Injection Drug Use Endocarditis Working Group, who have this amazing series of videos on YouTube. I was going to encourage you to watch them, but then I realized that you would all just see a better version of the presentation that I just gave. So maybe don't, but they are very helpful if you want to look at them. They also have someone with lived experience. They have a harm reduction nursing section and some cardiac surgeons who speak. So super valuable, super valuable resource. And then happy to take any questions. And then there's a reference. Oh no. Oh no. I lost my, okay, wait. I think I'm supposed to put this up. There we go. Sorry.
All right, thanks, Elise. So this is the QR code for feedback for Elise. I'm sure she'd appreciate it. We have just about 3 minutes for questions. Any questions from the audience? In the back, Mr. Haggerty.
Yes, hi. My question is more like, I'm wondering about when we set up patients with possible failure. If they're being admitted, like we've seen a lot of patients that get admitted here and are in treatment, and then they leave when it's checked in, and they don't come back. I was wondering about scheduling, like, like scheduling somebody has surgery like 2 or 3 days after check-in is not really going to work, or having them check into the hospital a week before check-in won't work well. Just wondering if there's a schedule and things that can be done where at least there's 3 weeks between or 2.5 weeks. Yeah.
Yeah, I mean, I think that's, I think for this population, as much as we can kind of meet them where they're at and facilitate, help to like reduce any barriers and facilitate anything like that we can would be excellent. I mean, I think a lot of that would depend on surgical timing and surgical availability, of which, you know, we often don't have control over. I do wonder, I mean, there's certain models of, like I saw when I was out at Redfish recently, where they have the checks kind of either brought in or deposited for people. I wonder if something like that would be an option, or yeah, even if we can't prevent, yeah, if there's ways that we could help facilitate that would not require people to leave. But I think it's a great point. Or, you know, find people often are having to leave because they're otherwise, you know, need to pay rent, are risking eviction. Like, I think those are common reasons that we see people leave. And I think the more support we have around that would only help. Yeah.
Well, just to say, I'm not a cardiac surgeon either, but I am in anesthesiologist who's worked extensively in our cardiac surgery ICU in Ottawa, which is home. And I will say that for the cardiac surgeons, this is equivalent to liver transplant in a patient with active alcohol use disorder. I think there's a lot of different aspects that they consider. The biggest piece being that we really do need that multidisciplinary care to make this work. From their point of view, the biggest risk is really reinfection risk, particularly with the installation of a prosthetic valve, which then requires redo surgery, which also has a much higher morbidity and mortality solely from trying to reopen the sternum with lots of adhesions to a beating heart.
Totally.
So I think it's important to just sort of understand from the cardiac surgeon's point of view, many of them are well-intentioned, and in Ottawa we operate on almost every infected endocarditis patient with very little stigma. I will say that we have that going for our center. And we're often involving our substance use team. Even when we didn't have an active substance use team, the medical director was so involved that they would personally text her and she would come and be involved in the care of this patient. So just to say that often the cardiac surgeons are just faced with this really complex situation where they're trying to do good, but they also recognize that this surgery is extremely high risk, it's very comorbid, and it's a very prolonged hospitalization that can have many, many complications. And you're also now setting this patient up to maybe need permanent anticoagulation, a pacemaker, et cetera, all these things that require a lot of management, and you don't want to initiate this process in a patient that might not necessarily be able to follow through with the requirements after the surgery. So I think that really the best step forward is engaging in that interdisciplinary care. That Ontario study that you mentioned is interesting. Only one third of patients were seen by an inpatient addiction medicine team. While outside of Toronto, no other center, even Ottawa, we didn't have an inpatient addiction medicine team, right? And we're the second biggest center in Ontario, and we only started a service in 2017 that shut down in 2020 and is restarting in 2023. So the reality is that like the gold standard of this care that we need is really that interdisciplinary model, and many of our provinces are not set up to provide that.
Totally. No, and I totally agree. And I do not at all mean for it to come across that like that surgeons are trying to be callous or anything by like no, but I think that's and I will say, like, watching the cardiac surgery perspectives on that the YouTube video, it was like it was very evident the amount of moral distress that people have about this. And one of the surgeons was saying, when we have to go in and do a redo surgery and someone's valve is just totally destroyed, like often there is not anything that we can even sew to, and that like to then have to like leave that patient on the table because you physically cannot fix their valve is like a horrific situation. And so I agree. I don't think that anyone should, or I'm not trying to say that people should just be automatically approved for surgery, but I think it comes down to that, like making sure that it is an informed risk benefit conversation with certainly like with addiction medicine, with multidisciplinary input to make sure that it is really like a risk benefit discussion. And in some people, the risk will be too high to proceed, and that's totally fair, but making sure that it is not directly at you use drugs, you are not eligible, like that the eligibility is based on a genuine risk benefit balance as opposed to a judgment on how they got it. But yeah, I totally agree. Yeah, like an incredibly difficult procedure with a lot of very challenging ethical considerations. Totally.
And we're after 1 o'clock, so I'm sure if anyone has any other questions, you can come down and ask them. But otherwise, thank you all for attending, and we'll see you back next month.